Okay, so really warm welcome to everyone on the call. Thanks so much. And please do say hello in the chat. It would be lovely to hear where you're coming from and anything you want to share about yourself. So this is the inaugural meeting of the Shame in Healthcare Network conversation series, and I'm delighted to welcome you. It's really wonderful to see so many people. We're thrilled to have this many people sign up to the group and turn up today. So this is very much a joint endeavour. I'm just the welcome on the door. So I'm going to introduce myself, say a little bit about the session, and then ask the others in the steering group to introduce themselves before we get going. My name's Susy Stirling. I'm based in Sheffield in the UK. I'm a public health doctor by background, and I work in medical education, running a clinical leadership and a coaching scheme. The goal of this network is that we become more aware of shame and its impacts and more competent around it. But another goal is that we get the chance to connect with others who are interested in this subject area. And the format is going to be a short talk by Will, and then you'll be invited into a breakout room with 3 or 4 others to connect and to consider a question in the light of what you've just heard. And then we'll return to the main room before closing. And the easiest way to manage this number of participants is if you stay in your breakout rooms until Zoom pings you back. You're going to have about 20 to 25 minutes discussion time. So without further ado, I'd like to introduce the others from the steering group before we get on to Will. So Sandy, I'm going to come to you first. Do you want to say hi?
Hi, everybody. I'm Sandy Miles. I'm a GP based here now down in Devon. I've been interested in shame in medicine for the last 7 or 8 years since doing a master's in medical humanities and focusing on this as my area. I teach doctors and medical students about shame in medicine, and I'm really excited to be part of this new venture to include as wide a range of group of people as we can in exploring this really important topic.
Thanks, Andy. Penelope.
Hi, everyone. My name's Penelope Lusk. Really nice to see all of you. I'm a PhD candidate at the University of Pennsylvania here in the United States. And I've been thinking about shame in medicine also since doing my master's on the topic. And I especially think about it around medical learning and learning about health. So really glad to be here.
Thanks, Penelope. Luna?
Hi everyone, I'm Luna Dolezal. I'm an academic based at the University of Exeter, and I know many of you. I have a research project that looks at shame in medicine that's funded by the Wellcome Trust, and it's something I've been researching and writing about for several years. I'm really happy to be part of this and be here. Nice to see everyone.
Thanks, Luna. Is Barry on the Zoom? I haven't seen him arrive. There is someone else in our steering group called Barry, but if he's not here, I'm going to gloss over him and come over to Will.
Great. Thanks, Susie. Welcome, everyone. And this is a really exciting opportunity for our little group, hopefully for those of you joining. And it's really kind of a full circle moment for many of us who've been working on this topic for years now to finally really feel like we're developing some much needed community around it. I'm a academic family medicine physician at Duke University, and I've been studying shame particularly in healthcare and health professions education for about 12 or 13 years now. And I have the opportunity and the privilege to be the first of our speakers in this conversation series. So thanks to my my colleagues for nominating me for this. And I'm excited for the opportunity to just hopefully center us a little bit on what we're talking about, why we're talking about it, and how we might begin talking about it. And so I'm going to just share some slides. The point of this is really to be a short, hopefully thought-provoking way of getting us on the same page about, in this case, shame and the difficulty in expressing and sharing it. In the future, about some subtopic that we choose around shame, really that's meant to inform some meaningful conversations among this little community we're building. So the real value here is in those connections and discussions, not the slides. But we do think it's helpful to provide a bit of an overview. Also, just want to acknowledge Bob Klaber and the Kindness Network. We're modeling this approach based on some amazing work they've done with their network. So I want to just give credit to them and their graciousness for sharing their ideas with us. Oops, sorry, wrong slides. I'm going to just pull these up, and I'll just kind of run us through them. Okay, so we're here to talk about shame. And is everyone seeing my slides? Can you see them, Susie? Okay,
Yep,
great.
great. Yeah.
And talking about shame, I probably don't need to tell anyone on the call here is not an easy thing to do. And I'm going to hopefully convince you, and we'll hopefully come to some agreement together that it is something that we really should and must be talking about. But we have to think about meaningful ways to do that. If you've been around me at all or heard me talk, you almost certainly have heard one of my most potent shame stories, which is really what led me to this spot right now where I am today. And I'm not going to go through the details of it. I am going to mention it because it really highlights the difficulty that we face in acknowledging and validating this emotion in healthcare and healthcare spaces. And when we've worked with shame over years, we work with a lot of metaphor. It's such a complex emotion. And one of the metaphors that has been helpful is the metaphor of fire. And if you think about a fire, it precipitates, or it's catalyzed, or it starts in some way. And for me, early in my residency training as a family medicine resident, in a period of time of a lot of self-doubt and some insecurity, maybe some healthy humility about my lack of skills, but certainly a lot of concerns about how I was being perceived by others and needed to prove myself, et cetera, I made a major medical error. And if shame is a fire, the error was the match strike. And this error occurred when I was on labor and delivery. I injured a mother during a childbirth severely. It was a very public error. It was very jarring. It was unexpected and simultaneously expected. It's like you just kind of live in fear of knowing you're capable of hurting someone as a learner and as a clinician. And you know it's going to happen, but you kind of are in constant denial that it could. It's this weird paradox. And in the midst of that paradox and all this insecurity, I made this terrible error that really hurt a patient. Now, if you had been around me, if you'd been outside of my head, my body, and you watched me after this error, you would have thought, well, that was a match strike, a flare up, and then an extinguishment. You would have thought that might have been a little bit emotionally distressing or traumatic for him. Maybe I hid it extremely well. I literally hid after I made the error. I mean, I left the room and went and hid for multiple hours before someone found me. I came back to work a day or two later, and I was probably more quiet than usual, but you might not have known that anything was wrong. In reality, I was dealing with, a brush fire. I mean, an absolute wildfire emotionally. And it was initially this big surge of fear and anxiety and fight or flight. But that then transitioned into, especially once that intensity died down some, into this really harsh, pervasive, intrusive self-evaluation. And I didn't really know at the time that's what I was doing, was self-evaluating. But I was. I mean, I felt incompetent and unworthy and stupid, untrustworthy. That was a painful feeling as a resident. I felt like I didn't deserve to be given any responsibility, and I felt like a bad doctor. I mean, I just felt like a bad person. The initial feeling of inadequacy around being a resident and around a proceduralist in an OB realm really quickly turned into being unworthy and broken as a caregiver, as a partner, as a son. I mean, it really was like a wildfire emotionally. We work with an artist. We call her our in-house artist now, Hannah. Mumby, who's from Exeter, actually in the UK, just such a brilliant soul. And this is one of the ways she depicted what this experience can feel like. This was depicted based on qualitative research we did in medical students about their shame, but it so many ways mirrors my own intense shame experience. At the time, when I came out of that experience, or actually when I was in the midst of it, it was extremely disorienting. I mean, emotionally disorienting. From an identity standpoint, it was disorienting. I just lost a sense of self so abruptly and severely. And it left me in this real limbo state. And yet I still had to go and do my job, and I had to go learn, and I had to go show up for other people, all the while internally just suffering significantly. And I didn't know what I was suffering from. And it took some somewhat painful soul searching and, more hours than I would like to admit in the Barnes and Noble self-help section, reading terrible self-help books before I finally stumbled on Brene Brown and learned about shame. And it was this incredible curtain that went up. I could see myself so much more clearly, my emotions. I could see the world around me in a different way. And when I went back to work with this awareness and with the beginnings of a shame lens, is what I would call it, what Luna and I have called it, I was more equipped with an actual term and concept for what I was going through and feeling. And it really did explain the bulk of my emotional state, and that being shame. And so I'm going to just define shame briefly here. There's many ways to define this. Narrower conceptualizations are problematic when we talk about shame because it is such a huge emotion. So the caveat here is this is an overarching way that captures much of what shame can be, but certainly not all of it. But I do just want us to be on somewhat of the same page as we talk about this emotion. Generally speaking, shame is a feeling that occurs in the midst of intense negative self-judgment. We feel often in response to falling short of a standard or a norm, like there's something globally wrong with us is the reason for that falling short or that transgression, the failure to reach an ideal. It's something about us as a more global, stable sense. My competence, my worthiness, my intellect, my attractiveness, my general skills, etc. Shame often brings with it a very potent and significant feeling of negative judgment from others. Many theorists and researchers would argue that there's always a component of negative self-judgment, whether it's from a real person that's standing next to us, whose judgment we perceive, or someone who's a projection of our imagination, as if they were across the room looking at us and judging us. So this feeling of being negatively judged, exposed, and broken or flawed or unworthy in some more global sense is the essence of shame. Now, shame can also include a variety of ways of feeling that are described with other terms like humiliation and mortification and rejection, embarrassment, etc. So there's an umbrella under which a number of emotional sort of experiences can fit within shame, but at its essence is this feeling of global negative self-judgment and judgment from others. So when I went back out with the beginnings of a shame lens and curiously started looking around me, like what I found after my error, which was nobody in my life, in my work, in my training program had any idea, A, what I was going through, partially because I wasn't telling them, and B, how to support me. I mean, they didn't even know how to ask me what I needed, and I didn't know how to answer, and I didn't know how to tell them. It was this void of support and understanding that I experienced. When I started looking around after the error and seeing shame everywhere, I started to really notice that it was there, but no one was acknowledging it and talking about it. When I went into the literature, deep into the literature, in psychology in particular, which is a terrifying place to find yourself deep in, I found that there was a lot written about shame in psychology. There was signal for shame in medical education and healthcare, but very, very little explicit acknowledgement of it in our community. And what that's led us to really think about is where shame fits into this broader discussion and emerging understanding about what it means to be well or not in healthcare. As an example of this, I'm going to tell you what I think is the biggest barriers, the biggest challenges to talking about shame. And I'm going to exemplify this with a search engine here that was produced by the National Academy of Medicine in the United States, their Action Collaborative on Clinician Wellbeing. And as a part of this big collaborative, which is a national, federally supported initiative, they created a knowledge hub where they gathered bespoke gathering of resources, papers related to well-being in healthcare and in clinicians. And you can go in and search among those resources. So I thought, well, let's see what these different terms yield in terms of the types and numbers of resources in this hub. And so you see the 6 terms down here. This is the results. These are the results that I generated, which are still contemporary results. This is the number of papers or resources identified based on these different keywords. Ironically, the 5 papers on shame actually aren't about shame. And sorry to say that none of us on this call who've ever published about shame are in this cohort at all. Essentially, despite this incredible presence and emphasis on burnout, stress, depression, concepts like shame, like trauma, self-esteem are severely, severely underrepresented in our scholarship and in our broader conversation about what it means to be well and to be in healthcare. And this is the elephant in the room that we're all sort of staring down and that we have the opportunity to build incredible community around. As a way of another way of visualizing this, I flew into New York. This is a couple of years ago, and these goofy, super tall luxury high-rises were being built. And I looked over and I thought, that's how it feels being a wellness researcher focused on shame. That we keep building this knowledge about concepts that are very real and very important. So I don't want to invalidate those. They are very important, and frankly, they've been extremely well researched. But we continue building knowledge vertically about these certain constructs that are in our lexicon, that are acceptable to talk about. And as we build up and up and up, we start to lose sight of what else is around us and within us. Okay? And I really think, and I think those of you who've experienced or worked with shame will prone to agree, that shame is this incredibly rich, powerful, prominent part of the experience of being a human, and therefore being a human in healthcare that we are generally not attending to. So, Luna, you might have said this initially. Somebody smarter than me said this, and I've just adopted it, that we're really working within this paradox of a present absence of shame. It's there, it's so there, and it's so often potently experienced in its variety of manifestations, and yet there's a real absence of acknowledgement, understanding, engagement, and research around it. And that's because I know this is a topic that is not easy to measure and to talk about, right? And this notion of this iceberg or something deeper and significant and fundamentally human is both an opportunity and a challenge to tap into. But we have to recognize it as such before we begin tapping into it. And I think there's a real power in that recognition that I'll explain in a minute. When we looked at shame in learners, this is just to depict the milieu that we're working within in healthcare in particular, and not just healthcare, capital H healthcare, but any service-oriented profession that serves others, especially vulnerable populations. This was a study of residents and what some of the impacts of shame were that they experienced. It aligns very much with a lot of the phenomenology of shame from psychology. But when we look at some of the factors that contributed, this is some of the milieu in which we exist in healthcare. These are high stakes environments. The standards for performance, for health, for how to show up are often very rigid. They're very explicitly defined, and they're often very exclusive, if not, generated by a small minority that are often, those in power. There's extreme focus on performance and the need to prove oneself as worthy, and then abundant perfectionism. Those standards are shifting all the time, especially for learners as they come out of the grades-based environment into clinical learning. And then out in practice, the standards by which we measure ourselves can be so nebulous and difficult and often painfully delivered to us. if you've ever had a bad review written about you online about a patient or a patient complaint. It's a real jarring reminder of medical error, of falling short of a standard. And there's a real emotional complexity that comes with that we're not acknowledging. And then there's just abundant fears of judgment. And frankly, some of the reason we fear judgment in healthcare is that we judge a lot in healthcare. We're a kind of judgy profession. And I think that's something we need to confront and really think about, and how to manage that judgment or the tendency to judge and why we might do that. Shame is also an emotion that naturally wants to be hidden. It's how it has this affective punch. It's how it has a lot of its evolved function, right? It's often through avoidance of shame that we adhere to social standards and that we cooperate with other people and in groups. So shame, by virtue of its nature in some regard, and then in a profession like healthcare, where being emotional, having emotions, struggling can be seen as weakness, we are naturally inclined to hide our shame. And that often is because we fear how others might see us in a shame state. Our shame often tells us untrue things, unexamined assumptions operating as facts, as we say, about how people are feeling about us or thinking about us. And then in particular, when we feel that judgment, the natural tendency is to self-protect, to hide, to disengage, to not continue risking feeling this way about ourselves or being seen this way about ourselves. And so we sit on it, we suppress it or repress it. And then the shame tends to go into hiding. And anyone who's worked with shame or felt shame knows that it never stays there, right? It may be hidden from our view, even as people, or certainly from others, but it exerts an influence over us, which can range. And, through a lot of different types of behaviors, coping mechanisms, et cetera. Donald Nathanson talks a lot about the shame compass, which is a bit of an adaptation, if not merging, of the shame compass. All the things that we do to try and bypass our really painful shame, much of which show up in our workplaces and with our clients and patients, with our loved ones. Generating the ability to recognize the shame that could underlie these is a critical part of advancing the shame conversation. Shame is also an emotion that makes us feel isolated from others. It also can manifest when we are isolated from others or marginalized or rejected. It finds incredible overlap with stigma. It's often, I think, Luna, we've talked a lot about it, is the affective arm of stigma. It's one of the ways that stigma exerts its ability to make us feel and be powerless. And not me. I'm rarely, if ever, in a powerless state as a member of the minority, and everywhere I go. Shame has that incredible, potent power to make us feel powerless and to often exist as an arm of stigma. So if we take this emotion, which can be so painful and difficult, how do we work with it in a way that feels hopeful? And that's a question that I think many of us have been grappling with for some time now. And frankly, I do not think I would have been ready to advocate for this network with my colleagues if I didn't feel like I was starting to come up with an answer to that. How do we find a hopeful way to manage shame? The good news is I think there is an incredibly hopeful way of working with this emotion that's very empowering. And it gets to the fact that shame is fundamentally a normal human emotion. We have evolved to experience it. It's when we experience it, if nothing else, it's proof that we're human and that we have a brain that's capable of self-reflection and self-evaluation. It's painful, but it's kind of an amazing reminder of what our humanity can do for us and what it is in essence. Shame is humanizing, okay? It can be humanizing. Denying shame is dehumanizing. What we are doing if we deny this emotion in ourselves, in our workplaces, in our patients, our colleagues, is that we are denying a fundamental aspect of the human experience. Therefore, we are dehumanizing ourselves. And when I finally wrapped my head around that notion, and other few people helped me think through that, it became a real simple, there's a simple next step to me. It's not an easy one to execute, but it's just that we begin humanizing ourselves by acknowledging this emotion, by engaging with it, by avoiding causing it in other people, by supporting ourselves and people as they go through it, by making this emotion a normal, living, breathing part of what it means to be a human. We can better get in touch with the very human nature that we experience every day. And that to me is a message of empowerment. It's also, I think, we need a message of empowerment if we're going to find a wide-scale engagement with this emotion that is, critical for change and transformation in healthcare. So Hannah also illustrated this panel along with the other one, which shows a little bit of what I'm talking about. And that's what we're after with this network. It's to acknowledge this emotion. This is the part about how do we talk about it? And we normalize it. We normalize it as it's a normal, healthy, albeit very painful and challenging emotion that can be unhealthy. We bring curiosity over judgment here. And that's curiosity about other people's experiences of shame over our judgment of them. And it's certainly curiosity about our own experiences of shame over self-judgment. Okay, for the reasons we feel them, as well as the existence of those feelings at all. We need to avoid assumptions. None of us can assume that we would ever understand how another person experiences this emotion. There are some universal elements to it that might give us some shared understanding, but all of us are unique creatures in unique environments. And rather than assuming that anyone might feel shame or experience the world like us, we need to be curious about the ways it might be different. And then through that curiosity, seek to understand better. We need to uphold personhood as we examine this emotion. So much of shame does tell us there's something wrong with us fundamentally as humans. By upholding each other as worthy, valuable people, just by virtue of our shared existence on this planet, we will facilitate a better ability to then engage with the difficulties of that existence and what our shame can tell us about ourselves. And therefore, we need to empower one another through this. I mean, this network is meant to be one of empowerment. Through these shared connections and community, we can go out and do the work that needs to be done in bringing this emotion into awareness and recognition in the way that it deserves. And then finally, we do that by building community. So with that, I'm going to transition us to the small group part of this. When we were with the Kindness Network many weeks ago, we really loved the opportunity to listen a little bit, but really then just to get into a group with 3 other people that we didn't know. And hopefully over the next number of months or years, we'll begin to know each other better. And just to talk a little bit about our reflections on what we heard, we want you to consider really, it's kind of one big question that's all linked. We want you to just share a little bit about any reflections you have on what I just shared. Maybe more importantly, why do you care about this topic? What makes you interested in it? What brings you into this network, spending time in the middle of your evening or your day? And why are you here? Like, what is it about shame that makes you interested and intrigued? And if it's just morbid curiosity that brought you to a shame network, explain that too. Talk about authentically how you see this emotion and then how you might want to see it engaged with as we move forward. We'll spend, what time is it right now? Okay, we'll take about 20 minutes, 21 minutes. If I just lay just a couple of really basic ground rules, this is a confidential space. That should go without saying, truly confidential. We have to all commit to that. And if we can't maintain that confidentiality, I would just ask you to just go ahead and fall off the call now and come back at the end for the large group discussion. Curiosity, openness, and acceptance are critical. And we all need to commit to this being a place of safety to the greatest degree we can develop, we can create it. And the last ground rule is that we could really try in your groups, you're going to have groups of 4, if you could each try to allow each other about the same amount of time to speak. So it won't feel like a lot, 5 minutes or so. But if you're a wordier person like me, please make sure that you kind of reel it in and let someone else have just as much time to talk. Okay, so Penelope, are we ready for breakout groups? Cool. So we'll see you back in 20 minutes. We'll do a little bit of